area or taken thin sections through that. So it's important to put a pain marker. This is a T1 weighted image. So at this stage, what do we think is the differential diagnosis? Okay. Okay, so we are having some differential diagnosis coming up, one being Baker's cyst, one being schwannoma, intraneural cyst, peripheral nerve sheath tumor, hemangioma, lymphangioma, cystic schwannoma, myxoma. Okay, so all of these DDs, fine. Let's look at them. Baker's cyst, it is not, because Baker's cyst, you will expect it to come from the knee higher up between the gastrocnemius and the medial gastrocnemius and the semimembranosus, and then it may extend down. This does not have any communication with the knee. So Baker's cyst will not think of. Schwannoma, yes, is a good thought, a possibility. One thing is on T1, it's very hypointense. And second, it's not along the known course of a nerve. So the tibial nerve is here. This is the tibial nerve. So it's not along the tibial nerve or the peroneal nerve. This is intramuscular. But yes, that's a thought which still, it doesn't have the target-like appearance. But still, yes, that's something we'll keep in mind. Also, if you note here, you can see the fat surrounding this lesion. So that is kind of, it can be seen in nerve sheath tumors, or it can be seen in any benign lesion. So basically, it's not infiltrating. The fat plane around it is maintained. Okay. The other thoughts were intraneural cysts. So again, it's not along the course of a particular nerve. Hemangioma. So hemangioma usually has a more lobulated appearance. It's not so well defined, and so it would have a more lobulated appearance. It's not so well defined single mass-like lesion. Lymphangioma, again, very well defined, small, but okay, we are still keeping it in mind. Myxoma, very good thought, because it's inside a muscle. So when you have an intramuscular lesion, a myxoma is a very good thought. Okay, so now we are thinking, so I think majority of the people are talking of lymphoma or peripheral nerve sheath tumor. So what would we like to do next to kind of try to differentiate between these two? Yes, so contrast, and that's what we have done. Contrast is here. I'll just show you the contrast images. It's always a good idea to take a pre-contrast FATSAT T1 to compare. Here it's a hypointense lesion on T1, so fine, but sometimes you can have T1 hyperintense lesions and you don't know whether they are enhancing or not. So it's always a good idea to have pre-contrast fat-saturated plain T1 before giving contrast. And this is the contrast in this particular patient. So this is the contrast images here. And we see very ill-defined, very flimsy, thin enhancement with it. And this is very typical of a myxoma. So this is an intramuscular myxoma. So the few things which we kind of learned from this case, the use of contrast to distinguish a solid from a cystic lesion, because sometimes these myxomas can almost look like ganglion. And you are thinking that, is this a ganglion? If the lesion is not in the expected location of a ganglion, there is no tendon here, no joint here, so I'm not expecting a ganglion within the muscle, then remember, a myxoma can mimic a cystic lesion. The way to differentiate cystic from a solid lesion would be to give contrast. If patient is not able to afford contrast, ultrasound is a very good modality. So ultrasound can easily tell you whether this is a cystic lesion or it's a solid lesion. Obviously, it's easier to diagnose that on ultrasound. Contrast, when given, myxomas can show various types of enhancement. It can show very thin enhancement like this, which is more common, but sometimes it can show more and more of a solid enhancement also. So very well-defined lesion, T2 very bright. We can always look at diffusion also in these cases of soft tissue lesions, but it helps as an add-on. So remember, a diffusion weighted image is not to be used as a primary image, but more as an add-on image. And here you can see that it does not show restricted diffusion. This is T2 shine through. This is a very T2 bright lesion. So it's not a solid, as in very cellular tumor like lymphoma or something which would show restricted diffusion. This is just T2 shine through. So intramuscular myxomas are very common. You can have myxomas subcutaneous and other locations, but that is less common. Intramuscular, typical myxomatous lesion, a myxoma. Okay. Next, let's look at another thing I want to tell you here is when we talk of soft tissue lesions on MR, you can classify it into two types of lesions. One, where the diagnosis can be made for sure, like say myxoma, hemangioma, lipoma, myositis ossificans, elastofibroma, these where for sure you can make a diagnosis on MR. The rest of the lesions fall into an indeterminate, or it's a soft tissue sarcoma, which is clearly very heterogeneous, aggressive, that's fine. But otherwise, a lesion is indeterminate, and it's fine to not give a diagnosis on MR. What the role of MR is more important to tell the extent, and in such cases, it's fine to put it as an indeterminate and ask for a biopsy rather than label it as benign and then later it turning out malignant. Because soft tissue tumors do not follow the rules like in bone lesions. You can have a very well-defined lesion which could be malignant. You can have a lesion which is very slow growing. For example, a soft tissue sarcoma in gluteal region. The patient may say very slow growing over a few years, but it still could be a sarcoma. So you can make a diagnosis and you cannot, and you call it indeterminate, and a biopsy is what is essential. So somebody asked whether it could be lymphangioma. Lymphangioma would be more cystic, and the cystic components, the multicystic component will show very slender peripheral enhancement. The cysts will show peripheral enhancement. Here it is within the lesion, there is flimsy enhancement. It's not peripheral enhancement. So this is not lymphangioma. Okay. Now that we have looked at this case, let's move to the next case. This patient is a 35-year-old male who presented with swelling in the hand, which has been there for many years, but now he feels there is some increase and he also feels some pain in the hand. So this is the T1 weighted image, and this is the corneal stir images. So this is corneal stir images out here. This is a T1 weighted image with fat saturation, and this is a plain T1 weighted image. You can see this lesion here, and this is a fat saturated T1 weighted image. This is a stir image. This is a sagittal PD image. Yeah. So what do we think it is? Okay. We are having some answers. Many are thinking lipoma. Some are thinking median nerve fibrolipomatous hamartoma. Some are thinking infiltrating atypical lipomatous tumor. And then whether we want contrast in this patient. Okay, so let's answer all of these. First, we are thinking of fibrolipomatous hamartoma of median nerve. That was a question. But if we look at it, the median nerve is compressed. You can see the median nerve here, and it is fully compressed by the lesion. Second thing is, this particular lesion is infiltrating both deep as well as superficial to the tendons. There is this very flimsy, thin septae-like appearance. But on FATSAT T1 weighted images, it is getting homogeneously. Where was the FATSAT T1 that we had? Yeah, it is getting homogeneously suppressed. Okay. Now, on FATSAT, we are not seeing any solid component at all. There is no no solid component, no areas of heterogeneity. This is all fat. So this was lipoma, which in hand and feet are less common, but do occur. Somebody said lipoma arborescens. So lipoma arborescens is intra-articular. When a patient is very common, especially in knee joint, followed by, we have seen cases in elbow joint, but mainly we see always in knee joint. Patient who has chronic synovitis, chronic synovial thickening and effusion, could be due to inflammatory arthritis, could be due to post-traumatic or any arthritis and then synovitis. That synovitis will develop areas of fat, which are like frond-like areas, and that is lipoma arborescens. So it's not like a separate entity on its own. Chronic synovitis forms a lipoma arborescens. So that's intra-articular, not in soft tissue like this. Okay. Would we call it a typical lipomatous tumor? So a a simple lipoma can also have thin septae within. It can have some vessels coursing within. It can have muscle fibers. If it's an intramuscular lipoma, you can have some muscle fibers traversing, and it's still a lipoma. There's no heterogeneity. I'll come to a typical lipomatous tumor. If there are flimsy areas of hyperintensity on stir images, yes, we can call it as an atypical lipomatous tumor. Management-wise, lipoma and atypical lipomatous tumor, there is no differentiation. Both will be managed similarly, resection. Only thing is, atypical lipomatous tumor, the follow-up may be done to exclude any recurrence, because there is a chance of recurrence in it, though not very commonly, but that's the only difference. And we need to differentiate it from liposarcoma, for which we are looking for areas of heterogeneity. We are looking for solid areas. And remember, liposarcoma may not always have fat, because liposarcoma has a whole different type. You have myxoid liposarcoma, you have chondroid liposarcoma, multiple types of liposarcoma. So the fat content may be less. Now, another here, so the very thin septae, which are not bright on stir and all, I wouldn't call it atypical lipomatous tumor, but yes, if you call it also, it's fine. As I said, morphology-wise, there is no, treatment-wise, there is no difference. A typical lipomatous tumor was earlier called as well-differentiated liposarcoma. But then they realized that this does not metastasize, recurrence is lesser. So unnecessarily the term liposarcoma, which sounds more scary. So it's been called as ALT, atypical lipomatous tumor. Another point I want to bring up here is, when you see a lesion bright on T1 weighted image, and you want to distinguish whether it is fat or blood, remember you need to do fat sat T1 weighted image. Do not rely on stir image, because subacute blood can also sometimes get suppressed on stir image. So just a point to be remembered. More reliable is fat sat T1 or fat sat T2 weighted image, but not stir image cannot be wholly relied on. Sometimes subacute blood can get suppressed on the stir images. PD in this as a part of the protocol for the wrist joint, it's just been run, but there is no real use for the PD images in there. And if there are any areas of heterogeneity, solid areas, giving contrast is always helpful. Here, because it was just completely fat, there was no solid area, and the patient could not afford contrast. Contrast was not given, and even without it, we are sure that this is not an aggressive lesion. As against that, showing this scan now, this is the stir image. I'll show you the T1 weighted image here. This is the T1 weighted image. Okay. This is the stir image. And in this patient, contrast has been given. This is the contrast enhanced MRI. Let me get the corneal image. Okay, no, what do we have? Yeah. So this is the contrast enhanced image. This is T1 weighted image. Let me show you the axial images. This is the stir axial images. This is the T2 axial images. Let me show you the T1 weighted image. Yeah. So this is plain T1. This is plain T1 image. And now this is what I mean when there is, yes, this is clearly liposarcoma, because in addition to the fat component, there is a non-fat component here, very important. Something like this can at times be calcification, and then we want to give contrast in this patient. And on giving contrast, this is the contrast enhanced images, and you can clearly see. So these are the very, thin septae like which are enhancing, but here they are thicker, and this is a whole solid component. So now the importance of MR here would also be to target the biopsy. The biopsy has to be targeted to this solid component. If you do not do image guided biopsy or just do it from this area, it will just show you something like lipoma. So the role of MR becomes to show the extent of the lesion, what is the involvement of the compartments, and to target the biopsy so that you do not go through necrotic area, you do not go through just fat area, you go through to the solid area and biopsy that area. So this did turn out to be lipoma. Okay, I'm just looking at some more cases. Okay. Yeah. This is the next case we are looking at. And here, this is the, okay, size criteria for septa, not size, but thickness. Yes, so if they have a typical lipopetous tumor, the septae kind appearance are very thin, just maybe 1 to 2 millimeter. It will not be thicker. For liposarcoma, CT can help, but CT, I would not, the soft tissue resolution would not be good enough for the vessels and all of that. So MR would be enough, and even without contrast, also on MR, you will be able to make out. See, that solid component we can make out on the plain scan itself, but we can give contrast to kind of show that it is enhancing. There is a whole group of radiologists in UK who, in fact, do not give contrast at all in any of the tumor cases, and they do plain scan. We like to give contrast to look at these enhancing areas and delineate them better. Okay, so this is now a 60-year-old person who's presented with a swelling which has been increasing for some time in the thigh. So now what are we thinking of? This is a very large lesion. This is T1 weighted image. This is the STIR image. This is fat saturated T2 weighted image. Remember, in tumor, you always want to do plain T2 also, because STIR shows you the lesion, T1 shows you the fat planes, and T2 shows you both. It shows you the relation to the neurovascular bundle. It shows you the internal architecture of the lesion as well as the surrounding relations. And this patient, contrast, has it been given? Yes, contrast has been given. And you can see this is the contrast study. Okay, so what do we think of the diagnosis in this? So this here is the femoral nerve, which is separate. It is compressed and splayed around the posterior margin of the lesion. The lesion itself is very heterogeneous, lot of solid areas, but some peripheral cystic areas also, which show some level also, but overall a very heterogeneous lesion. Yeah. So this is something, because it's separate from the nerve. Again, I will not think of a nerve sheath tumor, but I'll label this as soft tissue sarcoma. And it's perfectly fine labeling it as soft tissue sarcoma and not going into the subsection. Calling this as a malignant lesion, a soft tissue sarcoma would be fine. Further, whether it's a spindle cell lesion, whether it's a synovial sarcoma, whether it is some myxoid liposarcoma, or more dedifferentiated kind of liposarcoma. So there's a lot of different types of soft tissue sarcoma which you may not be able to make out the differentiation, and that is fine. The role of MR is to say that this is a soft tissue sarcoma, and then the biopsy will be done for further. Few things like, say, pleomorphic sarcoma will show a tail-like appearance. So there can be some clues. You have this one, alveolar small part CA, small part tumors, which can show a lot of blood vessels. So certain things can give you a clue, but you may not be able to make a histopath diagnosis. It's perfectly fine calling these as soft tissue sarcoma. Now, again, the role of MRI is to tell the extent. So which compartment it is there, what is happening to the neurovascular bundle here. It's compressed, there is no fat plane, but it's not encased or anything. And it is there in this, it's anterior to the hip joint. Sometimes is it involving the bone? A large lesion can be eroding the bone. So MR is more for extent of the tumor. Okay, we move on to the next case. Okay, so this is a 22-year-old girl who's presented with pain and swelling in the thigh. So more history I'll provide you, but if we can just look at the scan first. Sometimes history is not always very clear about things. So first let's just look at it and then I'll tell you the history. We always obviously need the history. Sometimes you ask for things later. After having looked at the scan, you decide what you want to look for. And let me show you the T1 weighted image. We have the sagittal T1 weighted image. This is the sagittal T1 weighted image. And let me show you the stir image. This is the stir image. So now what are we thinking? And before we look at more history. So sometimes, the history is only pain and swelling. Okay. We are, so answers are abscess, hematoma, tuberculous infection, ruptured cysticercosis, intramuscular abscess, and hematoma. Okay. Yeah. So I think kind of we are on the right track. So two things. One, you can see edema is significant. So there's this lesion and then there is a lot of edema around it, which is very important. I'll show you the contrast, but first let's just look at what we are seeing on the plane images. And then we'll go to the contrast. So the lesion is in the rectus femoris muscle, significant surrounding muscle edema. It has some little lobulated appearance at some locations. And also on T1 weighted images, I hope it is projecting well. Can you see little hyperintense rim? Slightly bright signal at the periphery. Okay. Center is very hypointense. And then we have contrast. This is the plane scan. Okay. This is pre-contrast. And then this is post-contrast scan. Okay. Okay. So what after the contrast, what is everyone thinking? Yes. So this is abscess. This patient did have history of fever and the blood WBC count and all were raised also. This is very typical of abscess where you have a little thick, irregular kind of wall. If we look at the wall, they are thick and irregular. I don't know why it's not scrolling. One second. Okay. Yeah. So it has got a thick, irregular kind of wall surrounding significant edema and the T1 hyperintense rim. So these are the clues. The T1 slightly hyperintense rim is usually always with infection, the significant surrounding edema, and this thick irregular walls. Infected hematoma, that is, the patient should have had some injury or clear earlier injury, or the patient is on blood thinner and then a hematoma and then that has got infected. But otherwise, as such, we'll think of this as a intramuscular hematoma. This turned out to be a staph aureus, was grown from this. So then it's important. The reason for T1 hyperintense rim is peripherally in infection, you can have a bit of granulation tissue-like appearance at the periphery, and that causes the T1 hyperintense rim. So that helps you distinguish a tumor from a abscess quite confidently, and then giving contrast also shows it well. So intramuscular abscess, and whenever you have intramuscular abscess, you want to see whether it is coming from an osteomyelitis focus or from infective arthritis. Here, this patient has only intramuscular abscess, often seen in children when they are given intramuscular injection in the thigh. So then they come with abscesses. or just hematogenous spread from some other infective foci, you can have abscess in the muscle. Ruptured cysticercus, this is too large. This is a very large lesion. Cysticercus lesions are very small. They're very small and cystic lesion. And typically the history is there is flare up, patient gets pain, swelling, which then settles down, again comes up. And the edema is disproportionate, but the size of the lesion is quite small. It's not this large. Diffusion, have we done in this? Let me check. Because diffusion, no, in this case, diffusion has not been done at all. Scolex may be seen, may not be seen at times. So many a times you may not see scolex, but you'll see a small cystic lesion, and edema is quite disproportionate to it. And when you ask the history, most often it will be like they've had similar episodes earlier also. Even intramuscular hydatid cyst can happen. Not very common, but we have seen few cases, but that would have the very typical appearance where you have the daughter cysts within. Some of them may have ruptured and form folded appearance. So that's very typical appearance. Okay. Yeah. This, I'm coming to the next case. This was I think 25-year-old sportsman. He used to play tennis, and then he's presented with pain. Okay. Pain and swelling along the dorsal aspect of the wrist. So this is the MR. This is the axial and corneal T2 weighted images. Let me show you the T1 axial images. Yeah, this is a T1 axial image. And in this, contrast was not given. Yeah. Yes, I think most of the people got it right. It is, okay, somebody asked the previous scan. Previous was abscess. Previous was an intramuscular abscess. The earlier one was intramuscular abscess for whoever. Yeah, I think all of you are getting it right. This is a ganglion cyst. Two things. One, it is a cystic lesion and also very typical location. And what is that location? What is the location which is very typical? This ganglion, maybe you can put in the chat. Periarticular which joint? Peritendons. Yeah, so this is typical dorsal scapholunate interval. This is the most common location for a ganglion cyst in the wrist. So this here, and you can see the small, it is the whole ganglion has come out subacute. But when I look carefully, I can see a small extension going up to the dorsal scapholunate interval. Yes, every ganglion we should try to trace to the joint or the tendon sheath, but we may not always be seeing it. But if it's in typical location, for example, in wrist, the three or four common locations, most common is the dorsal scapholunate interval. See, this is the scapholunate ligament dorsal, and that is where this is coming out. So this is dorsal scapholunate interval. You can see this here. Other common location is the piezotracheal joint. So the piezotracheal recess, superior or inferior to it. Another common location is scaphotrapezoidal joint. So this is your scaphotrapezoidal joint. You can have a ganglion there. And the other common location is radioscaphoid. Anteriorly, ventrally, radioscaphoid. So these are very common locations for wrist joint ganglia. Similarly, you have ganglia in the around the tendons, ganglion joining the joints in the ankle. You can have ganglia in the ankle in the sinus tarsi. Sinus tarsi can degenerate. So this is dorsal scapholunate interval ganglia. Now this is a very large one, very obvious. Sometimes a dorsal scapholunate ganglion may be just 2 to 3 millimeter big, and that can still cause significant pain. So that's the importance where you put a marker, so that you're looking very carefully at the area that is called as DOCG, dorsal occult ganglion cyst, dorsal scaphoid unit occult ganglion cyst. It can be really small, 2 to 3 millimeter lesion, but still could be causing a lot of pain. And at the same time, you may have these ganglia asymptomatic. Like so many times you're doing wrist scan, the patient has some TFCC injury or extensor carpi ulnaris tendinosis, and then there are these dorsal scaphoid unit interval ganglia. That's why important to put a pain marker so that you know whether that is the cause of pain or not. Here, clearly, the pain marker is right overlying the swelling and the swelling is seen. So even an ultrasound would be good for this, and ultrasound could also show this equally well. You can see this extension here. Usually it's located in this location only, but here it has a superficial extension. Let me show you the sagittal images. Yeah. So you can see this superficial extension. Otherwise, normally you'll see it only here, deep through the extensor tendons. But here it has gone out. So the pain marker, there are multiple types. You have these commercially available specific pain markers, but they do work out expensive. So what we use is the vitamin E capsule because it is fatty. So it would be bright on T1 weighted image. So just a vitamin E capsule, you put it there. Except I'll tell you certain conditions. EVN marker, yes, you can put it. So glomus, when you're looking for glomus of finger, do not put a marker because the glomus is like hardly 1-2 millimeter glomus, and you put a marker, it will get squashed. And fat set will not happen there properly. So glomus, I always instruct the technician to just write on the note, where was the pain? Was it more ulnar side? Was it more radial side? Was it in the center? But don't put a marker. Similarly, if it's a very subcutaneous exophytic kind of lesion, a small lesion, and then don't put a marker right over there because it will squash the lesion. Yes, we put the marker with a regular surgical, the plaster tape. Yeah. So this is ganglion. So remember, ganglion are seen in typical location. If you see something like a ganglion or a bursa, but not in the typical expected location, please be very careful. Confirm that it's a cystic lesion by either giving contrast or doing ultrasound, because, like I said, myxoid lesions. Similarly, you may have synovial sarcomas, which are para-articular, and they can look very much like a bursa or very much like a ganglion. So a ganglion or a bursa, but not the typical, something looks like it, but is not typical location. Please make sure that it is a cystic lesion. Often, we have seen sometimes that it gets missed. A solid tumor is diagnosed as a ganglion. Okay, let's go to the next case. Okay. This is the stir image. This is the stir image that I'm showing you. I'll show you the other sequences later. This is the yes, USG can help to distinguish between cystic and solid. Somebody asked that question. Yeah, so here is a lesion. Okay, let me show you the T2 weighted image. So remember, any tumor imaging, bone tumor or soft tissue tumor, stir and T1 weighted image in the longitudinal plane, axial T1, T2 and stir, sagittal, either T2 or stir, any one of them is fine, and then diffusion and contrast. Okay, we are further seeing this, and I think all of you are getting the diagnosis right, which is good. Let's look at T1 weighted image also. Yeah, so this lesion does have few of those signs. One, very important to trace the nerve on axial images, because corneal and SAS don't tell you whether it is nerve or not, because they can be average. So we are looking here. This is the sciatic nerve. Okay, this is the sciatic. The sciatic nerve, the tibial component. Okay, and as you come down, okay, no, it's the sciatic nerve. The branching is higher up, lower down. So see, but in sciatic nerve, remember, you have the tibial nerve and the common peroneal nerve separate. So here, can you see the common peroneal nerve is almost on the surface, but the tibial nerve I'm not seeing separately. But along the sciatic nerve, okay, there is a nerve sheath tumor. It has got these central hypointense areas fat plane around it is maintained, it is fusiform. So everything which is telling us this is a nerve sheath tumor. Okay. Now, coming to the other question. Okay, let's look at the contrast. So invariably, these will show quite solid enhancement. See, the central dark area which is here is not enhancing, but rest of the lesion is enhancing. You can see the nerve here. So this is a nerve sheath tumor. Now, can we distinguish neurofibroma and schwannoma? Not always. So in fact, that's the reason we always put it as a nerve sheath tumor. Now, a target sign, central hypointense like this, is more common with neurofibroma. If I can see the nerve separately and this is more exophytic, more likely schwannoma. If the nerve itself is fusiform and enlarged, it's more likely neurofibroma. But it's not always possible to say. So that's the reason we will call it nerve sheath tumor. And remember one more thing. A very well-defined lesion like this, homogeneously enhancing, can still be malignant peripheral nerve sheath tumor also. So you'll just call it nerve sheath tumor and not really say whether it's benign or malignant. If you tell me this patient has had this little bit of swelling he had been feeling for a few years, and now recently in last few months it has increased in size, it is painful, high chance that this could be malignant peripheral nerve sheath tumor. So imaging wise on M, you may not be able to distinguish. If you can see something aggressive, very ill-defined, infiltrating the adjoining tissue, then yes, you'll say malignant peripheral nerve sheath tumor. Otherwise, you'll just say a nerve sheath tumor, whether it's benign or malignant, may be difficult to say on MR. Neural paraganglioma and ganglioglioma, and how to differentiate from peripheral nerve sheath tumor. So see, we'll call this as a nerve sheath tumor, ganglioglioma, paraganglioma, all of those will be more in the neck, in the mediastinum, and not really in the peripheral nerve sheath areas. So these nerve sheath tumors will typically be along the course of the nerve, whether it be intercostal nerve, any nerve, it will be along the course fusiform. While the paraganglioma and ganglioglioma are not usually along the course and exactly fusiform. They can be any shape. And between neurofibroma and nerve sheath tumor, and schwannoma, you may not be able to distinguish. Diffusion, yes. So there are articles which talk of looking at the ADC value, which will be lower in more malignant lesion. But again, there can be an overlap. So to me, I'll call this as a nerve sheath tumor. If this is something which has increased recently in size, suddenly the patient has developed pain, they have to exclude a malignant peripheral nerve sheath tumor. Just on imaging, I may not be able to say. If it is invading adjoining structures, very infiltrative, then I'll say it's a likely malignant peripheral nerve sheath tumor. Target sign, more common in neurofibroma. And typically, again, history, can they be biopsied? Yes, they can be biopsied. Okay. And clinically also, they have that Tinel sign positive, very painful on. Okay. Let us move to the next one. So see, if the history is fitting into a slow growing one and it's very well defined, imaging wise, everything is fitting, they may just operate. But if there's this biopsy can be done. There is no problem in that. Okay. Okay. So nerve sheath tumors of spine. So nerve sheath tumors of spine can be epidural. They can be intradural, extramedullary, and epidural, both, a dumbbell shaped, which is going from the intradural compartment outside into epidural, then into the foramen, into the adjoining nerve root. So they can have that typical, they cause scalloping of the adjoining bone. Again, they can have central target-like appearance or not. So when you have an intradural extramedullary lesion in the spine, the two main diagnoses are going to be meningioma and nerve sheath tumor. Okay. We are looking at this case now. And what we see here is, this is a T1 weighted image. This is a stir image. This is a T2 weighted image. this is the fat sat sagittal T2 weighted images. And this patient now, if you look, has these very hyper intense thin areas. There is no solid component really, but there are all these very thin areas, no solid component. And this did turn out to be a typical lipomatous tumor. It did not have any solid component, but it had very thin hyperintense area. So remember a typical lipomatous tumor, which was earlier called as a well-differentiated liposarcoma. Now the term used is atypical lipomatous tumor. Having said that, you may sometimes have just a lipoma, especially in locations like the back. Because of trauma, because of lying down, there is trauma there, and that can lead to fat necrosis. It can lead to some edema, hemorrhage there. So you may see very small areas of, in lipoma, you can see these changes also. But this turned out to be an atypical lipomatous tumor. But if there's any doubt, any solid area that you see, then you should raise the possibility of a liposarcoma and target the biopsy to that particular location. Okay, so this is the case that I want to show you. This was a, I think, 35-year-old male who presented with pain first and then swelling in the back. Left back, there was pain and there was swelling. Okay, so I'll show you the sequences slowly. This is the sagittal stir images. Okay, this is sagittal stir image. This is the axial stir image. I will show you the T1 weighted image. Okay, this is the T1 weighted image. This is the coronal T2 weighted image. I'm focusing on the pathology only itself. One second. They didn't do contrast in this patient because sometimes, patient is not affording, they're not able to give contrast. But I'm showing you very specifically these two images. Okay, these are the two images that I'm showing you. Okay. And another thing is you can see all this edema. This was all the edema around it. Okay, so let's see what, these are the two specific images I'm showing you. Okay, so let's look at the choices everyone's coming up with. Tuberculosis, elastofibroma, soft tissue sarcoma, tubercular, infective. So most of the people are leaning towards infective. Some thought of soft tissue sarcoma, and some are thinking of Ewing's, basically sarcomas, tuberculous, and elastofibroma dorsi. These are the three thoughts that we have, everyone's answered till now. Okay. Elastofibroma dorsi, I know why you're thinking, because of the location. But few things. Elastofibroma dorsi will not show you so much of edema. Elastofibroma dorsi is not well defined, rounded like this, and also it's here in this location. The serratus anterior latissimus dorsi, between them there, and it looks almost like muscle intensity. Stir, it can be a bit hyper intense, but usually it is very ill-defined small. This, if you notice, is adjoining the medial inferior pole of patella. This is where this is the lesion. Okay, let me just kind of, okay. Adventitial bursitis doesn't look solid. Doesn't look cystic. This looks a bit solid. And two, why so much of edema? Would you all agree that the edema is very disproportionate to the lesion, size of the lesion? TB. Many people thought of TB. Okay. Now, on this image, if you will appreciate, the rim is not hyper. Can you see a hypo rim? And the center is not very dark. the periphery is hyper. On T2, you can see the periphery better, but whatever you are seeing there on T1 is hypo. You agree? And the edema is very, very disproportionate. I'm giving you clue. The edema is very disproportionate. It is none of the diagnosis which has been said before. Osteochondroma, I'll see continuation with the marrow. I'm not seeing any continuation with the marrow. Chinmay, you're not supposed to answer. Okay, yeah. Mets, soft tissue mets, like, so this is a soft tissue lesion, it's not in the bone. Cysticercus would be cystic. This is solid. Okay. So very typically, this is where we all, like when I started reporting MRIs, I very clearly remember I saw a scan like this in a child. And my first thought was, oh, this is soft tissue sarcoma. And then I did dynamic contrast and trying to plot graphs and all that. And then my professor came and he looked at it and he said, what are you thinking? I said, soft tissue sarcoma. And he said, do you have the X-ray of the child? They had not done X-ray, they had directly done MR. And X-ray or CT will just, all of you will tell me the diagnosis immediately. Yeah. Can you see this here? So remember, when you have a lesion where the edema is disproportionate, look very carefully at the lesion. If that lesion has a hypo-intense periphery on both T1 and T2 weighted image. See, the minute I showed CT, all of you could diagnose very easily. But the question is to know when to do the CT cuts. If you think of this as a soft tissue sarcoma or an abscess, then you would not take CT cuts. So remember, a hypo-intense periphery, very disproportionate, much more disproportionate edema. Just look at radiograph or do CT cuts, and it is myositis ossificans. Why this is important? Because if you go ahead and biopsy this, if you report it as sarcoma, if they go ahead and biopsy this, a pathologist, for them, it looks just like an osteosarcoma. So in fact, the report will come as osteosarcoma, which is very scary. So here you don't want to biopsy also. This is going to mature and become more ossified. Cystic tuberculosis, no, because I'm seeing calcification and this disproportionate edema. The clue is the disproportionate edema. Heterotopic ossification, so that is what myositis ossificans, the etiology is not known. Maybe there was trauma, maybe there was no trauma. It's essentially ossification happening there. So tuberculosis, no, because the edema will not be so disproportionate and this is solid. If you look at it, it is solid. Okay, yeah. This was the case I wanted to show you. Okay, so I think probably we have time for a last case. Let's just look out this case. Yeah, this I just wanted to show you. So, patient has got pain in the tip of the finger. I think the history itself is quite suggestive. So this is a, one second. So this is ideally a place where I do not want to give, put a pain marker, but here a pain marker has been put and luckily the lesion has not been squashed. So the important thing is to look very carefully. I don't know if we have given contrast. This is not the best of the case to show it, but the reason I wanted to show you is the location. So when you look very carefully, you have this small lesion here. And when I look at a sagittal image, yeah, can you see this? So usually these glomus tumors are dorsal, but it can be anywhere in the subungual region, this nail bed area, even from this periphery, it can arise, glomangioma or glomus tumor. So can you see this? So you need to look very carefully and dynamic contrast or even ultrasound can help a lot. So glomus is another lesion. In this location, the other common pathology could be an epidermal cyst or epidermoid cyst because you may have had some prick, some foreign body thing, and then there could be an inclusion cyst. That will be more well-defined. That is usually larger. These are small. They can be large at times. You may have osseous involvement, but very small lesion. So you have to be very, very careful. Look at the site of the pain very carefully. Dynamic contrast helps you a lot. This is not an inclusion cyst because it was very significant. An inclusion cyst will be larger, usually following some kind of a injury or something which has taken some of the squamous cells into the fingertip. Okay, so I think on time we have finished. Any questions as such? This was again an atypical lipomatous tumor. I just wanted to show you for that reason. And the reason that especially the back tumors can have, because of trauma, you may have some fat necrosis in areas like this. Another case I had opened, but I'm not able to find right now, was fibromatosis, which is dark on, the whole lesion is dark on T1 and T2 weighted image. Let me just see. Okay, let me end with this particular last case. Let's look at this and then we can end. Yeah. So this is not fibromatosis. That case I'm not seeing. Posterior chest wall lesion, that was myositis ossificans. The questions I'll just answer. Let's look at this last question, last case. This here. This is the lesion here. Medial gastrocnemius. See this here. So what do you think is the diagnosis? This is STIR. This is T1 weighted image. This is sagittal T2 weighted image. This is the gradient image. So this is a hematoma. So remember, Morel-Lavalley is subcutaneous and fascia. So Morel-Lavalley collection is between the fascia and the subcutaneous tissue because of shear injury. This was a hematoma. The point which I want to convey here is, when you see something like a hematoma, there should be clear trauma, direct injury, hit to that place, or the patient should be on blood thinners or something. If it's not in a common location, if the patient has not had any injury, patient is not on blood thinner, look very carefully whether it's a hemorrhagic neoplasm. You can have soft tissue sarcomas into which there is hemorrhage. So if it's not typical location, no trauma, no blood thinners, be very careful. If you still think it's hematoma, make sure you follow it up for resolution and not directly leave it as a hematoma. Especially on ultrasound, a lot of soft tissue sarcomas are very often diagnosed as hematoma. Okay, so we need to be careful about that. Okay, so I think that was the last case. Let me answer questions. We can't diagnose the lesion. Yes, so if I'm not able to make out what the diagnosis is, I'll describe the whole lesion. I'll say the etiology is indeterminate and a biopsy is recommended. Other questions was, how do you guide the technicians? So I think if we spend some time on training them, it's possible. So there is a clear tumor protocol. There is a clear internal derangement protocol. Tumor protocol, this is what it is. The minute you see a mass lesion, do this. And according to me, what I think is, if we don't settle for it, if the technician initially you have taught them, they are doing a mistake, make them repeat, let them call up the patient, call back, make sure it's done. They'll realize if you are strict about it, about what you want, you get the sequences. It does take an effort to set it up initially, but I think this is standard, like a tumor protocol, whether it is a bone tumor or a soft tissue tumor, is quite standard. Other question is, if you don't see ganglion, you may not always see because the extension into the joint may be very thin, but it's a typical location, dorsal scapholunate, the typical locations which are there, I would still call it a ganglion. And I know it's a cystic lesion. Left posterior chest wall was myositis ossificans. Any other questions? Fibromatosis is usually both T2 and T1 dark. There can be some areas which can be bright on T2, and these are the areas which are more cellular. So at that point, if you operate and all that, they recur more. When it's fully hypointense, it's more of fibrous, and that time the recurrence is lesser. Yeah. Some areas, but the entire thing won't be T2 bright. Okay, so any other questions? Otherwise, we can end the...
Ma'am, there are a few. Can I just put them across?
Yeah, sure. So there was some Q&A thing also.
Yes, ma'am.
Okay. Let me look at the Q&A. I think I was looking at the chat.
Yes, ma'am. So how to
Oh, yeah, I can see it now.
diagnose?
How to definitely diagnose myositis ossificans and malignant soft tissue with calcification. So, calcification in tumor will not be peripheral. So, the ossification, myositis ossificans starts peripheral and then goes central, while the tumor ones are usually central and more stippled and coarse and all of that. So, it's not a problem. And the edema is disproportionate. Neoplasm, you will never get so disproportionate an edema. And the peripheral ossification. How to identify T1 and PD? Fluid is dark on T1. PD, the fluid is more like T2, more towards T2. And then look at TR and T, if that is also a doubt. Can a large soft tissue sarcoma and hemangioma be each other's differential? No, usually no. Hemangioma, okay, again, hemangioma I didn't show. Hemangioma is more lobulated T2 hyperintense with interspersed fat areas, which does not happen in a soft tissue sarcoma. Neurofibroma versus schwannoma, I already answered that. Hematoma and tumor. So again, I said, if it's not a typical location, if you see any solid areas, give contrast in what looks like a hematoma also. But remember, do a pre-contrast FATSAT T1, post-contrast, so that you can subtract that. Otherwise, T1 hyperintense area, you'll never know whether it's enhancing or not. So subtract that and then look for it. The cavernous hemangiomas don't show arterial phase enhancement. Sometimes there can be a little few arterial feeder-like things, but mainly the enhancement is in the venous phase. Does not show arterial phase enhancement. Glomus tumor, like I said, it's a small, very small lesion. T2 bright, T1 it's ISO, you may not see it. Idea is to pick up that T2 bright area and give contrast also. Heterotopic ossification and osteosarcoma. Yes, so myositis ossificans and osteosarcoma pathology looks the same. So that's the reason you don't want to biopsy this, because it will come as an osteosarcoma. That peripheral rim of ossification is very typical. PD, no. So here, PDs have been done because it's a part of the protocol, but no, in tumor, PDs don't have. Different variants of soft tissue sarcoma. If you're seeing myxoid areas, you may say. If you're seeing the tail appearance, you may say, but not necessary. It's perfectly fine to call it as a soft tissue sarcoma, but describe all the extent. That is very important. Okay, so I think
yes, ma'am. That's all the questions. Yeah. Thank you. This is just last one. STIR versus FATSAT. I think we can skip that question.
STIR versus FATSAT.
Yeah.
Okay, so STIR is useful where there is large field of view and curved surface. Such places, FATSAT will not happen homogeneously. Okay, so then you will be confused. Or instead, but the resolution of FATSAT T2 is better than STIR. STIR is more grainier. So you can use sequences like, say, IDEAL, which will allow homogeneous fat suppression. Slow flow AVM, I didn't show. So venous vascular malformation, very lobulated T2 hyperintense areas. On T1 weighted image, you will see some fat interspersed in between.
Yeah. Yes, ma'am. Thank you so much. We have some encouraging compliments and comments in the chat box. And I know how much important all these things are because I've learned so much from you. And